The following presentation was recorded at the 2017 ANZICS Safety and Quality Conference.
That makes me very happy. So thank you for inviting me to speak about improving communication with dying patients. And I guess the first question is, why should we talk about this? We're intensivists, it's all about saving lives, at all costs. And we're really good at that. So why this focus recently in many forums to talk about end-of-life care? And it's more than recent, but why is intensive care so interested in it? And firstly, professionally, we should be interested in it because the Choosing Wisely campaign, which is a great representation of what we care about, the number one item is for the Australian Critical Care Choosing Wisely campaign through the college is about better end-of-life care. And you can't read that, it's just I put it up there to remind me to talk about it. Is that it talks about offering choices to patients and establishing their goals and values, and we'll come back to that. So there's professional reasons we should, as health professionals and particularly critical care health professionals, do it. There are personal reasons, and we've all got these. If I was to ask for a show of hand of who in the room has had someone close to them die, actually I will ask for a show of hands for who in the room has had someone close to them die. So it's almost all of you. So this is personal. This is more than just delivering medications at the bedside. My sister said the problem with having an extrovert in the family is that when my father died, they all got sad internally, and I wrote an article in The Age about it, and that it was a call for attention and I should have a good hard look at myself. But my father's death following a sort of prolonged dementia from a very active GP who was funny, engaged, loved life, was awful. And the article I ended up writing in The Age was about his last week of life, where we really struggled in an acute health setting, hospital, to get palliative care. And eventually I had to sort of pull the trump card of being an intensivist to achieve that. As a result of that, I got involved in Death Over Dinner, which a few of us in Geelong did when Michael Hebb, the founder, came to Australia last year. And I ended up at a late-line dinner with the ABC with actors and comedians as the sort of token health professional. And just last week, Charlie and I hosted a Death Over Dinner in Geelong, where we had sort of some leading figures in Geelong there. And it's a fascinating opportunity to get the community to talk about dying and death and their attitudes. There are political reasons. If you're Victorian, there are particularly political reasons at the moment to talk about dying, as we're about to debate assisted dying legislation in our state. But there's a lot of interest in all of our institutions. We all put person-centred care as one of our values, pillars, strategies in our hospital strategic plans. So there's a lot of push for better person-centred end-of-life care. And of course, there's social reasons. If you want to write a bestseller like Ken, you should write about end-of-life care. People will read it. Atul Gawande's book, Being Mortal, is a bestseller on Amazon. When Breath Becomes Air, Paul Kalanithi's talk about his end of life as a neurosurgeon. It's a bestseller. The Fault in Our Stars is about dying, and it's one of the highest grossing movies of all time. So this idea that society doesn't want to talk about dying, I'm not sure there's any evidence for that. I can't believe I'm using Twilight as evidence, but anyway. So, on to the question. So, can we improve communication with dying patients? And what I'm really talking about is shared decision-making. And we have been running a program in Geelong for the last 3 to 5 years, I guess it started, trying to improve shared decision-making. And so what we're talking about is identifying the goals and values of patients who have a life-limiting illness, and then aligning the care that we offer them with those goals and values. And one of the sort of central tenets of that is that there are choices. So, and that choice may or may not involve intensive care sometimes, but it might be intensive care, palliative care, surgery, whatever. We're not gatekeeping, we're offering choices. And I'll come back to that. So what we designed is we got a whole group of people to go to various places in the world. They went to Cambridge to do the Calgary, Cambridge communication course, Harvard. They've got some difficult conversation programs there that are really good. We have some local experts who trained in both. We looked at all the evidence and we established this faculty and 2-day course to, active-based, interactive, small group sessions to train people in how to communicate and follow this process of identifying patients with a life-limiting illness, establishing their goals and values, giving advice, etc. That took a while, and over a couple of years we refined it. The first couple of times wasn't great, but now it's pretty good. We've put, I think, now 120 nurses and registrars through the course. We've run a lot of introduction sessions. We're doing 4-hour workshops for senior medical staff, and a lot of sort of hospital forums just to keep people educated. What we're trying to achieve is that we get them to follow these steps, and the first one is to identify patients with a life-limiting illness. Now, that sounds like it should be easy, and perhaps you just know what they look like at the end of the bed, but we're pretty convinced that's not the best way to do it, that just sort of that subjective idea that I can pick who's probably going to die in the next year isn't great. And certainly there was an article in JAMA just in the last couple of months that to me supports that we're not that great at predicting survival most of the time. So we used the UK gold standard framework criteria for life-limiting illness, which is a community-based sort of palliative care type list of criteria, and they have the surprise question, functional indicators of decline and clinical indicators, and we just used the easiest thing we could find, which were the clinical indicators, because we wanted something that doctors and nurses at the bedside could easily use without having to think too hard about it. And we tested it in our population. We tested it in over sort of 2,000 patients, and it was metastatic cancer, that sort of frailty, nursing home, dementia group, and then the organ failure group were these 3 clear groups who had greater than 50% mortality at 1 year after being in hospital. So we thought, this is good. We found a group of patients who are at high risk of dying. That's a perfect group of patients that we should talk to about their care in the next year. And again, you don't need to read this, but this is just to talk about what we were trying to achieve with shared decision making. So on the left, and this is our new goals of management form, which is very process driven. So it makes you assess the patient, do they have a life-limiting illness at the top, establish their competence and find out who the surrogate is. And then what you're supposed to do in that box in the middle is write their goals and values down, your advice that you gave them, and then you kind of consensus what you agreed at. On the left is the before group, and these are untrained medical registrars, well, untrained in communication medical registrars. And they did what everyone kind of does, and what we see 90% of the time when we go looking carefully at goals and management forms, they just write, the patient did not want CPR, but would like all other interventions, and ticked HDU care, which is a kind of middle-of-the-road way to do it. So we say that's a fail. So although even though that's a bit mean, isn't it, to say fail, they've completed a goals of management form. So from a purely, do we have goals of management forms available, completed in all our patients, you could say yes. But there's no evidence of the patient's goals and values being discussed. There's actually not much evidence they even know this is going on. On the right is the new electronic version, where you can't read it, but where our registrar, who's trained and done the communication training, has talked to this little old lady about all the things that matter to her. And so it's quite complicated because her husband's got dementia and she wants to be around unless he dies, then she doesn't really mind what happens to her in terms of independence. About the medical advice, and she had some urosepsis and aortic stenosis, and so again there were some nuances of care for her. And in the end, she actually said she's happy to be ventilated if it's all looks reversible and gets her back to her husband, but she doesn't really want to go through aortic valve surgery unless there's a really big discussion. So there's a few things about this. The first is we're clearly not gatekeeping. So we have agreed that she can come to ICU for care. And one of the criticisms we got as an ICU running this program is this was all about excluding patients from intensive care, but it's not. we also don't think we're going to offer crazy things to everyone, and this isn't just about autonomy and letting patients do whatever they want. We all agreed this was an appropriate care plan. So that's what we're trying to do. So what happens when you release 20 ICU, when you train 20 registrars in communication and release them onto the hospital? So we've just done this before and after study. There's about 120 patients in each group, and they've got a mix of life-limiting illnesses. And what we saw was an improvement in patient-centred care. So you see at the bottom it went from 50% to 70%. Now, to give you an idea, at the moment in our general medical wards in our hospital, and I would challenge most hospitals that it'd be similar, we have somewhere between 30 to 80% of patients have got a goals management form completed, but only 5% of them have got their values written down somewhere. So the baseline of 50% was pretty good, but that's because we've been running iValidate for a couple of years and we're a little dirty. But 70% seems good. Our goal is to get it up over sort of 90%. Encouragingly, the group of patients who had died by 90 days after ICU admission, a values-based goals of management went from 43% to 94%. And so that's good. You know, we're talking to these patients who are at the highest risk of dying about what they want and the care they'll get. Did it make any difference or anything? And this is interesting. This is pilot study, hypothesis generating data. So the cancer group, we improved survival. Now you'd say, well, that's ridiculous. How can talking to people improve survival? There's a couple of possibilities there. One is that there's some sort of change going on in the hospital that we're not aware of, that oncology found out that we're running a shared decision-making program and hid all their patients from us. It's unlikely. It's not the history of oncology. But that something happened in the referral base, but maybe that's okay. It could be that patients are making different decisions. We know from some of the other palliative care cancer research that patients who receive good palliative care can have a mortality, a longer survival with higher quality of life. I'm not sure, but the good thing is we didn't exclude cancer patients from ICU, and they appeared to do a bit better. So it sort of encouraged everyone to keep going, even though that shouldn't be the outcome. The frailty group, who to us are really interesting because we hadn't really focused on frailty until 5 years ago. So there was no difference in ICU admission, in survival with the frailty group, but there was a pretty marked decrease in 90-day readmission. And having thought about it a bit, that's, I guess, what we would expect, that this is a group of patients who come into the hospital who perhaps don't have much that we can do to improve their trajectory of decline. You know, it's urosepsis, little things. We're probably not going to make much of a difference to their survival, but if we can help them not keep coming back into the hospital and perhaps die at a nursing home or wherever they were, that's an okay outcome. Again, it's it's small numbers, so it's very much hypothesis generating. What we've moved to now is that was just getting ICU registrars and sending them out and not giving them any support. And we realised that wasn't good enough. And if you look at all the evidence around communication training, you need to do a bit more than that. You need to have a system. You need to remind people. You need to have the nursing and allied health involved. And so that's what we're doing now in our ICU. We've got this all-of-unit program with all these steps, and there's posters everywhere. We nudge people at the 11 o'clock meeting. There's an electronic form that clearly hasn't been filled out, and we're sort of feeding back to them, and everyone's involved. And we think it feels like we're seeing a culture change in the unit, that people are now talking about goals of management as this sort of routine, values-based care, and they're all sort of proud of it. That is an extraordinarily amateur attempt at slide making on my part, but that's the percentage of patients with a life-limiting illness in our unit who've got their goals of management completed while they're in ICU. The 30% line at the bottom is the most hopeful data I can find for the rest of our hospital. In truth, I think it's around 5% at the moment. Even though the ticker box completion of goals of management is up to 80% in the rest of the hospital, it's very much just ticking ICU or HDU without anything being written. We're up to over 70%, 75% as we keep training registrars and getting this program going. So I'm hopeful that we'll be able to get over 90%. There are some difficult patients in here, those complex patients who are sort of renal, vascular, who come in as HDU patients to the unit for 48 hours for something. It's not easy to fix all of their goals of management while they're in the ICU, because you don't quite feel that you've got the agency to have that when you've got these very interested teams, and so we may have to have an escalation of that program for these sort of more complex patients. And equally, there's the really low acuity soft HDU patient who comes in and goes in less than 24 hours, who we sometimes don't get to, and again, I'm not sure that that's a fail either, as long as they get followed up on the ward. What are the benefits of this? What are we actually trying to achieve here? So from a personal level and a compassionate level, I think this is good. I think aligning care with patients' goals in their last year of life makes sense as compassionately, and certainly the feedback we get from families who have experienced this and staff is that it's a wonderful program. I'm not sure that's enough to convince a hospital or a government to invest in expensive training. I suspect what we'll see is different outcomes. We may see some survival benefits in some groups. I think we'll use our resources better, so it may be that we get referred cancer patients who will benefit in ICU as opposed to those who won't. I think there are groups like, from the evidence around the world, we will reduce unwanted, perhaps useless interventions at end of life, and that will probably be a cost saving, or at least a cost transfer to other things, but we've still got to prove that. And I guess finally, if I've got a minute, to tell you a story about a patient. So there's a guy, Jim, who's 75, who has metastatic bowel cancer. And this is about 6 weeks ago. And he I was on overnight, and I came in the morning, and so metastatic bowel cancer, palliative chemotherapy, less than 6 months to live is what he's been told. And I come in at 8 o'clock in the morning to find him in the intensive care on noradrenaline through his MRI port, or portacath, or whatever you call it, wherever you're from, with sepsis due to bowel sepsis. I had that sort of sinking feeling of, what are we doing? This is terrible. I didn't even know about it. And on his form, it was ticked, no conversations, just ICU care. This is really awful. So I went and spoke to him, and we had this 20-minute conversation. And these conversations only take about 20 minutes, and he said he had his bowel cancer for sort of 6 years. He'd had 6 weeks of palliative chemotherapy, which was intra-abdominal chemo, and it was the worst 6 weeks of his life, and he wanted to stop. What he wanted in 2 weeks' time was to go to the Gold Coast with his 3 adult sons and their families to the World Lawn Bowl Championships and have this big family holiday. And I tried not to go, oh my God, who'd go to the Lawn Bowl Championships? But I just smiled. And that's what he wanted. And he wanted us to get in there. And then he wanted to come back, and he wanted to stop his palliative chemotherapy and die at home, like his wife had 6 years ago with metastatic breast cancer. And we thought, that's a lovely goal, and that seems like the thing we should do. So we said, okay, we'll help you with your vasopressors and try and get you through this, bowel sepsis, and get you back, and aim to get you to the Gold Coast in 2 weeks. His oncologist turned up and said, yeah, that's a great plan. He said, look, I'm prepared to be ventilated only if you think I'll still get to the Gold Coast. You guys seem pretty trustworthy. We'll leave it at that. It's a big mistake. But he got there, and I rang him last week because I knew I was coming here, and I said, what happened? And he said, I got to the Gold Coast, I was pretty exhausted, it wasn't that great, I've come home, and I'm going to stop my chemotherapy. And it was, the whole plan has worked out perfectly. So the iValidate, which is the name of the program, didn't change his immediate care. Like, he still stayed in ICU, and he still got ticked ICU. But I think it has changed what happened since, in that it started these conversations about, well, what happens in the community, and his family are immensely grateful. The worst bit is he doesn't remember me at all. And I had to sort of, get over the the narcissistic tendency to feel Paul, and but his sons remember it all, and they all remember everything, and it's all good. But he doesn't remember anything. And so that's another thing I think we're going to have to look at, is follow-up conversations to work out. And he's happy with all the decisions, it's all good. But he doesn't remember that conversation, which I'll never forget, in ICU. And that's it. Thank you.